to share, more I get old and more I become full of doubts, of things that we continually repeat as dogma. We paste and copy, paste and copy, book, conference and conference, the same thing. Sometimes I think it's important to stop and to start to think. And this is just to think, well, let's see, this is the first CT we published, the past century. And you see, this is a man with now, at the time, to see for the first time this picture was quite impressive. Now it's quite common. But please, look here. I have 5, 10, and 100 of PEEP. I don't see any great recruitment. Look at the heart size. It's not very different. And we have, look at the PO2, 97, 100, 3, 104. Forget secondary primary RDS at the moment. But look here, 70% density at 15 of PEEP, 30% in the lung. But look at the heart size. In both cases, the heart is surrounded by black, which are the lung. I change the pressure of 10 centimeters of water. In one case, the airway pressure. So in one case, nothing happened. In the second case, a lot of happened. So I asked many distinguished colleagues which section all the heart in preload, pre-preload, the driving pressure, elastins, recoil, all these very beautiful concepts. And I asked them, and I ask you, if I take plus 20 into the airway, and I take a picture of your heart, I look at the heart dimension, okay, and then I take minus 20 around the chest wall, and I look at the heart dimension. What do you expect? Are they the same? Are greater? Are lower? I asked many experts, and they have different opinions. For somebody it's greater, for somebody it's smaller. I took a picture, so I know the answer, but I will tell you later. If you think about gas exchange, everybody, I mean, if you go from 70 to 60 millimeters of mercury of oxygenation, are you afraid or you start worried? Well, a little bit. If you go from 42 to 43 of PCO2, do you mind? Nobody minds. Now, how much is the PCO2 coming into the lung? 45. Getting out, 40. 5 millimeters of mercury. How much CO2 has been exchanged? Let's see, 200 milliliters. How much is the PO2 coming into the lung? It's about 40. How much is the PO2 getting out from a normal lung? About 100. How much the oxygen exchange? 200 milliliters. That means, in terms of gas transport, 10 millimeters of mercury, 10, 11, are more or less equivalent to 1 millimeters of mercury of CO2. But nobody cares much about this. And this is the why we breathe. And we breathe to clear the CO2. This is an old experiment. We were designing this experiment to think into the CO2 dialysis for the chronic lungers. But then we wanted to, we saw what's happening to the lamps, spontaneously breathing lamp when removing the CO2. And the lamps were decreasing their own breath, their own ventilation, down to apnea, so respiratory rate 0, tidal volume 0, and the animals survive. These were done, this first experiment in AV, so the oxygenation was not affected. And the animals survive by keeping the lung inflated with oxygen. And we repeat several times this in spontaneous breathing and in mechanical ventilation. Now, what tells us this kind of experiment? That we'll have to have a constant PCO2. As soon as I remove something with an artificial lung, or sometimes during dialysis, I start to decrease the ventilation because I eliminate less CO2. This is in mechanical ventilation. When I decrease the ventilation, what happens to the RQ, respiratory quotient? Decreases. Let me give an example. You have a patient in dialysis, and in dialysis, the patient is breathing room air, and you see that the PO2 goes down a little bit. The PCO2 stays there constant. And you say, well, why? And now you see that, let's see the normal breathing room air. You remember the equation, the alveolar air equation. Simplified is alveolar PO2 is equal to the inspired PO2 minus the PCO2 into the lung, divide the RQ. Let's see that inspired PO2 is 140. I have a 40 in my lungs, and my RQ is 1. I have 100 of PO2, I get an arterial oxygenation of PO2. Now somebody tell me out some some CO2. I start to decrease the ventilation with normal PCO2, but what's happening to the RQ in my respiratory system? Goes down. How much is 40 divided 0.5? Becomes 80. If I'm breathing 140 minus 80, my alveolar PO2 is 60. And the oxygenation, the best oxygenation I have is 60. And so sometimes I see my young colleagues during maybe when playing with extracorporeal support in spontaneous breathing, that maybe the patient decreases ventilation because now, I was speaking, I think in 2 days, now the fashion is the ultra-protective strategy. If high breath is bad, zero breath would be the best. But you know, there is always a balance. We have a lot of intrinsic risk also in lower tidal volume. Hypercapnia, who cares about hypercapnia? My dear friends, hypercapnia means hypoventilation. Hypoventilation means reabsorption atelectasis. Reabsorption atelectasis means the lung becomes a piece of stone, and when the poor heart, right or left, has to pump through a piece of stone, has some problem. Out of equations. And this is the FiO2 that I require to maintain a fixed PaO2 alveolar PO2 when I decrease the RQ. When I stop breathing and I'm removing all the CO2, there is only one gas which maintains the alveolar PO2. It's 100% oxygen. If I give 99% oxygen, in a few hours I get nitrogen into. You can play with extracorporeal support in a lot of ways, but we have to remember a little bit of some basic physiology. Because we may dissociate the oxygenation and CO2 removal. To oxygenate, we don't need any ventilation. We need just the blood flow. And when we give some oxygen equal to the oxygen which has been consumed in the periphery, 250, 300, it's okay. I can get out perfectly oxygenated. I can remove the CO2 from a smaller amount of blood, only because I have a higher content of CO2 into the blood. So I need very high ventilation and low flow for CO2, and no ventilation and high flow for PO2. And in this schema, look in the era of low tidal volume, super protective strategy, ultra protective strategy, and all the studies which are going on. Why we use this tool? To oxygenate? Well, I mean, everybody knows that the flow is enough, the pressure is enough. You can maintain, you may have a patient with 30, 35 of PO2 for weeks or months without any problem. So the problem is not really the oxygenation. Well, I give 5 liters of blood flow with extracorporeal circulation. Great. Good idea. To do what? The problem is, of the extracorporeal support, is to treat the lung gently. But I ask you a question. If I have a moderate RDS, or what we call is mild RDS, do we really need to have 3 milliliters of tidal volume per kilo? When we have about 40–50%, which is completely normal of the lung. What is the added risk of mechanical ventilation now, when we use not 12 per kilo, but we use 6, 7, and so on, in moderate and severe RDS? Are we sure that we have a great risk added by mechanical ventilation, or the problem is another one? So we should sit down even before to design the study and think what we really want. With the dissociation of mechanical ventilation through the membrane lung, we may have a great possibility of treat the lung gently. But this apparatus is not innocent. It's enough to see one bleeding, intracranial bleeding during extracorporeal support, maybe after 10 cases, 20 cases, 30 cases, to be extremely careful to put tubes and to circulate blood outside. I'm doing this thing since 40 years almost. So I know the risk behind. And a few words about the high flow. You say, great, I need high flow for oxygenate. I need 4 liters, 5 liters, perfect. And it's indifferent to be venous or venous arterial. You have to go to the equation for that, but believe me. But now let's assume I put all my blood in an artificial lung. Okay? 5 liters. What's the PO2 coming out from the artificial lung? Let's see, is 500, because I use 100% oxygen, or 600, great. Now I have 600 PO2 traveling to the normal lung. Let's see that my normal lung is perfectly healthy. How much will be the transfer of oxygen through the normal lung? 0. Because the blood is completely saturated. The improvement we have in oxygenation are due to the fact that we increase the PO2 in the shunted areas. And we have also to remind one thing, that when we put an extracorporeal support here, all the vasoconstriction that we have, and people say, okay, well, but vasoconstriction during RDS is dampened, blah, blah. So baloney. This is the white lung, 20, 40, 60% with a CT scan is completely white. We know, and this is the functional shunt. And you see, we have up to 50%, the functional shunt is still there, because this means vasoconstriction. Now, and when we put extracorporeal support with a high flow, And with a high PO2 coming in the venous side, this is lost. So immediately after, the shunt goes from 20 maybe to 70% during the extracorporeal support. So forget in most of the case of the extracorporeal support for the oxygenation. The artificial lungs are the best use to give a freedom in treating the lung gently. And in a couple of days, I will show how the lungs are treated during the extracorporeal circulation, which is done nowadays. I was a little bit terrified to see that. But anyway, I will stop here, and I will tell you what's happened to the lung when I put plus 20 or minus 20. If I give you the 2 CT scans, same patient, same man, you cannot distinguish one from the other. They are exactly the same. I thank you for the attention.